Hi, it's Mark Chris from Memorial Sloan Kettering, speaking today about a clinical problem that many of us are faced with, and that is there a role for retreatment with a checkpoint inhibitor for patients who had previously received a checkpoint inhibitor and now relapsed? Not a lot of data in this area, and there has been a recent paper in Clinical Cancer Research in the August 1st edition by Dr. Yakamatsu. And in that paper, they took a cohort of 59 patients. 41 of them had had a CR or PR with their first checkpoint inhibitor. Another 18 had either had stable disease greater than 6 months. The median time on the checkpoint inhibitor was 8 months. The median time off the checkpoint inhibitor was 9 months. And 20 of those 59 patients stopped the checkpoint inhibitor because of an immune-related adverse event. They gave these patients nivolumab, and what they found was overall, and I think this is the biggest message, the response rate, CR plus PR rate, was 9%. So the chance of helping these patients, even with prior benefit, was small. The median PFS for this group of patients was just 3 months. What they also discovered was 12 of these patients had a serious immune-related adverse event, and it's a total of 18% for the people that didn't have one previously. And of the people that had a serious adverse event previously that made them come off the checkpoint inhibitor treatment, 5 of those 20 had a serious immune adverse event. So the rate of serious adverse events is 2 or 3 times the rate of benefit for these patients. So again, the risk benefit is probably not there. What predicted, now making things more difficult is, of course, some patients did have some benefit. They had 5 responders. Of those 5 people that had a response, time off checkpoint inhibitor was the most predictive. And the other thing that was predictive was whether they had adenocarcinoma versus squamous. Patients with adeno did better. So as usual, we don't have absolute clarity here, but my reading of this is that the chance of benefit with another checkpoint inhibitor is less. It's low. It's less than the incidence of serious immune adverse events. And it's something that you just don't jump to. Does it have a role? Yes. Have some patients been benefited? Yes, but it's a small role. So what do you do in these patients? Personally, I would go to a different class of drugs for them. If they had not previously received chemotherapy, I would give a combination chemotherapy. If they have received standard therapy, such as cis or carboplatin and pemetrexed, I would then go to an alternative therapy. And my personal go-to here would be docetaxel and ramucirumab for these patients if they had previously received chemotherapy with their checkpoint inhibitor, or if they had received chemotherapy and needing another line of therapy. Of course, a clinical trial would be a fit if one is available, but I think for the most patients, you would need to go to a different chemotherapy. So in summary, we are thankful for some data guiding us in what to do with retreatment. Very limited benefit from retreatment with a checkpoint inhibitor, even in patients that had some benefit previously. And the chance of immune adverse events of a serious nature are high, double or triple the response rate that we see. So in general, not a go-to treatment. Does it help some patients? Yes, but only a small number.